Hi everyone, I'm Morgan Pollock, and tonight we're going to be talking about my critical appraisal of a study that was done involving spirituality and spiritual caring and the nurse-patient relationship. The study that I had to critically appraise was called Spiritual Caring Nurses, Perspectives, Practice in Palliative and Acute Care Environments. Now, the problem that was presented in this study is that spirituality is really a vast thing, and it means something different to everyone. So it can be hard for someone to articulate, and it can be hard for people to remove themselves from how strongly they believe as well, to be able to just set aside their biases and give that spiritual caring that is so imperative to the nurse-patient relationship. And it is something that has been identified that isn't done as well as other things in the nursing field. So why is this relevant to nursing? It's relevant to nursing because you have, like I said, that nurse-patient bond, which is key. And if you can't give 100% of yourself, so to speak, then you're not giving that true nurse-patient relationship, and you're not getting that bond if the patient doesn't feel like they can really confide in you and trust in you. And we all know that patients will tell nurses things before they'll tell the doctor, most likely, or they'll tell the nurse things that they won't tell their family for whatever reason. So we really need to establish that very strong bond. And if the patient sits there and asks us to have a spiritual conversation, we need to be able to honor that, whether it be because our patients are at the end of their lives, because we are caring for patients in that time of their life, or if they're, really injured. And some people blame spiritual things, whatever it is that they believe in, on like, oh, I got cancer because I was bad, or, I sinned, or things that really do come out in patients. And we need to be able to have that comfortable conversation with them. We really need to help patients heal from the inside out. And that is something that, especially at the end of life, patients need to feel like they are in touch with whatever their spiritual being is. The other thing that we need to look at is, what was the purpose of this study? Now, the purpose of this study was to identify any barriers, personal or environmental, that keep us from truly having this spiritual caring being given to patients. So, and the point of this was, if we identify those barriers, then we can actually identify them, we can scrutinize them and figure out what we can do to make it better, and we can move forward. And as a whole, nursing care is going to improve if we can identify these barriers. The study model that was used in this particular study was conceptual, and I say it was conceptual because it was a smaller idea that addressed a greater issue, meaning that, we have these barriers and spiritual caring isn't being given, but the greater issue is then the whole nursing care isn't being complete, and that bond isn't really being formed if we can't do this. So that's why it was conceptual. It was a smaller idea that addressed a bigger idea. The variables in this study were conceptual as well. And I say that because we didn't have a and B that was manipulating each other, or one manipulating the other. So we didn't truly have a dependent or independent variable. They were conceptual because it was the correlation between one group and another, palliative care and acute care. There weren't any in particular interventions in this study. It was more so theoretical interventions, like if we identify the barriers that are keeping us from doing spiritual caring, then we can address them and move forward. And raising awareness is something that the study really talked about, but they weren't interventions, so to speak. It was more theoretical work. The sample size was 7 hospitals in Sydney, Australia. We used acute care and palliative care nurses. The director of nursing services was really involved in how we got the groups picked. They helped us, I shouldn't say us, I didn't do the study, but they helped the researchers advertise and really get the right people involved. Now, some advantages and disadvantages of that, you have to question, were these people handpicked to participate in this study? Did the director of nursing services in a way say, you know what, Betty Sue's a really good palliative nurse, let's make sure she's in this group because she's going to make our hospital look good? Is a disadvantage. An advantage would be cluster sampling, which is what this particular one was. It's very cost effective. It's usually more done in a very timely manner. And I say this was cluster sampling because we took groups of nurses and we took like groups of palliative care and groups of acute care. We didn't just say, fill out this questionnaire and we'll pick you from it. After they were picked, they filled out a socio-demographic questionnaire and we went from there. It didn't influence how we picked them. So, there were 2 different types of tools used to question these nurses, so to speak. So there was no attrition rate as well. There was no power analysis because there was no attrition because we didn't have any loss of participants. There was no power analysis because it was just a correlation. We included things like acute care settings and palliative care settings were part of the inclusion criteria because obviously environment are 2 totally different. So we needed to keep that in mind. Things that were excluded, there were nurses that worked at high dependency units in the acute care facilities. They were invited, but they actually did not participate in the study. So could we call them an exclusion? We could, but it wasn't like a no, we don't want you. They weren't chosen. But there were no specific exclusions. Ethical components in this study, the directors of nursing services were contacted and then the ethical board gave approval. So that was all addressed before the study took place. And then to go back a little bit, the data collection procedures that were used, which I briefly kind of talked about, was the spiritual perspective scale and the spiritual scale practice questionnaire. The results were that, they're 2 different units and it's 2 different things that we're addressing on these units. So, some of the things that were identified was patient privacy and the amount of time spent with patients. And in conclusion of this study, really, we found that we need to allow more time with patients and figure out a way to have more patient privacy. And once we do that, spiritual caring will kind of come hand in hand. And we really did realize how important spiritual caring is to the nurse-patient relationship in this study. So that's all I have for tonight, guys. Have a great night.